So thank you guys all for coming. I'm very excited to talk about this. This is I'm going to focus on a project that we are just wrapping up data collection. So some of the data I'm going to share with you is like hot off the press. I know I recognize some of the faces in the room, so you heard me talk a little bit about this project before, but hopefully there'll be some new stuff in here for you. And we had our big end of the project CAB meeting yesterday, so I'm a little bit wrecked, but bear with me. Which one do I press? The right one?
It should be, but it's not working. So.
Okay, well, I'll just do this. This is fine. So first, I just want to recognize my team. I have a huge team. I have not done any of this by myself, and you'll notice one familiar face at least on here. But this is me and J.D. Smith, who is my co-PI at Northwestern University. He was a postdoc here and then went off to Northwestern, but we got to keep collaborating. And then a whole bunch of other co-investigators. I won't get into everything that they do, but I do want to recognize Tom Deshawn, who is the creator of the original family checkup program that we adapted, and he passed about a year and a half ago. So still in our slides and still in our hearts. And then these are some of the other folks that work with us. And this doesn't even include all of the student workers and all of the interviewers. So I just want to say it's a very big team and we can't do this kind of work alone. And then 2 babies were born during this project, so I gotta recognize them. On the right is on the left is my baby, Talia, and then Mila is the little one on the right. Definitely a big part of our team. So today I'm going to talk a little bit about why we've decided to do the work that we have done and how we came to adapt the family checkup program to address pediatric obesity and related health behaviors. I'm going to talk a little bit about the Raising Healthy Children study and the participants in that study, their service utilization, and then predictors of their engagement in the program. And can you help me with time? Yes. Okay. So the work that I do over in the Reach Institute in the Department of Psychology is primarily around family-based interventions. And we have many evidence-based interventions that are included on all of those registries that people like to put after the name of their program. But we found that all of these programs kind of have core components. They're very similar to one another. I'll put that right out there. I am definitely agnostic with related to programs, but we've had effects on mental health problems, substance use, sexual risk behaviors, teen pregnancy, HIV, and STDs, academic underachievement, school dropout, suicide, delinquency, bullying, violence, incarceration, obesity, parental depression, family conflict, child abuse, and neglect. But in general, we have not done a very good job at all in getting families access to these kinds of programs. So that's really my focus in this work. And we really don't want to be delivering these programs at the university. That is not our mission. So the focus is really figuring out how to get programs like these that we know work into settings that families actually can use. So primary care is a relatively new system for us that we've gotten to be interested in a little bit. A lot of the work before has been done in community mental health centers or in schools. And we think there's a lot of potential for primary care because of the reach. Over 85% of kids have a primary care visit in a year. They have longitudinal contact with their pediatricians. The parents are involved in those sessions, whereas in school-based programs, you really want the parent to be involved, but that's just not their context. It's not where they are. A lot of them have had negative experiences with schools. But for parents, they come to well checks. They have a lot of trust in pediatricians. They're focused on behavioral and physical health. That's their main thing. So why wouldn't we be there? And then, unfortunately, the academic side of me is like, sounds kind of ugly, but the existing billing structures in primary care are really critical in terms of thinking about ways to make things sustainable. Because we've tried things in schools, schools are chronically underfunded already, and trying to add another thing on that they're supposed to do just isn't going to work. I should also mention, please feel free to stop me at any point if you have any questions or you want to make any suggestions. So the project, one of these interventions that has all these effects on all kinds of outcomes is the family checkup. So we'll get a little bit more into what that is. It's basically broken down into really 4 steps, but there's an initial interview to get a sense of what the family's goals are and kind of come to the same page there. Then there's a comprehensive assessment where we're getting to know families. Predominantly it is, self-report, questionnaires, that kind of thing, all normed and validated. But then there's also a interaction task where we'll give parents and children something to do together. We film it. And then we use that both for our data and for clinical reasons, where we will actually show parents what's on the video and say, like, look what you did right here. That was so amazing. Like, let's figure out how we can get you to do that every time. So then that all happens at the feedback session, where we're presenting the results of the assessment to them and helping them prioritize what do they want to do next. So, we say, you guys are better than average compared to national norms on this, this, and this. And then here's an area maybe we want to work on together if you would like to. So those traditionally in the original family checkup model these are kind of like the outcomes that could happen, the follow-up services that families could get. So a lot of it's, very behavioral health focused, but it kind of boils down into, like, if there are needs related to parenting and child behavior, then we use the everyday parenting curriculum, which was developed kind of within this program. But it is a manual that you can just buy at Barnes & Noble or Amazon or wherever and just use it as it is. But it can also be embedded within this. And it has 12 modules, so we can really hone in on specifically what the parents need and focus on that. So a lot of parenting programs are like A to Z. You have to do the whole thing. Doesn't matter if you really need help with parent-child relationship quality, that's where we're going to start. And if you really need help with discipline, we're not going to get there until session 8. So bear with us. So that's for that. And then if there are other types of needs, say related to like parent employment, for example, or parent mental health problems, we would help them connect with resources in the community. The providers use motivational interviewing to help families engage and prioritize.
A question.
Yeah.
And apologies if I missed this. What age groups?
Well, so yeah, I didn't say that, but family checkup is being used all the way from age 2 until like teenage years, and then followed up actually into young adulthood. So a lot of the studies that have used this model are what we call health maintenance approach, where it's like you meet with them every year. It's kind of like your primary care or your dental visit, where you're going in for your checkup, and that's the term family checkup, and then following up with any needs that you might discover. But yeah, the whole span. For younger kids, the outcomes were primarily focused on like conduct problems, school difficulties, and for older kids, substance use, things like that, delinquency. So just to get kind of a little bit more into the content of it, or the processes behind it. It's very much focused on the family. So not to say that the family is to blame for things that are going wrong, but the family is the key to making things go right. And that's a really important distinction. I was actually just at a session at my daughter's school. It was actually a substance abuse prevention program that they were delivering to parents. And I was sitting next to a friend, and she said, after the guy said, parents are the key. And she's like, look at him, he's just blaming parents. Like, isn't it interesting? We have to be really careful about our words and how parents will interpret them. It's assessment driven, so everything that we do with the families is based on what their specific needs are, and that gets into the tailored approach too. So it's very much customized. We can't say it's a 10-session program. We have no idea how many times we're going to need to meet with the families. It's really up to both their needs and their interest availability. We use a lot of motivational interviewing, as I said, to get them engaged. We use that throughout the process. It's a really big piece. Strengths-based. So we, like, my favorite, this is kind of a MI thing, but my favorite, thing to ask families is, what's worked for you before, and how can we adapt that so it can work for you again? And then this health maintenance approach that I just mentioned. So it's like a long-term, ideally, we're working with the same provider every year and going back to that same person. I know there's always turnover in this field, but to the extent that we can, that's what that looks like. And then just kind of thinking about what it focuses on. There's this theory behind it that, you can fill in the blank of what child problem behavior you want to talk about here. But child does that X behavior, and then the parent gets upset and doesn't really act, or acts without really thinking about it. And then the child escalates, and then the parent escalates. So this is this coercive cycle. And then the parent usually gives up. So you can imagine a kid in the grocery store walking by the candy aisle saying, I want this. Parent says, no, you can't have candy. The child throws a temper tantrum. The parent yells at the child. Eventually gets to the point where the parent says, okay, here's your candy bar. So that's kind of the context that a lot of us parents, myself included, end up in. But this is what we're going for here. So the child does the problem behavior, I want the candy bar, and then the parent responds in a different way to result in de-escalation and then staying engaged with that child, so that when there's positive behavior that's reinforced, and this involves like setting things up. So maybe you distract them when you're walking by the candy aisle so you can avoid that conflict altogether. So as I mentioned, this was really a behavioral health focused intervention to begin with. So as you would expect, we have had improvements in parenting, child self-regulation, school readiness, language acquisition. So this is for the younger group that I'm really talking about. We have other kinds of outcomes for the older kids, but like substance use, sexual risk behavior. And we have reductions in problems at home, irritability, which does not get enough attention, I think, but that's a big one for a lot of parents. Anxiety and depression, both on the part of the child and the parent. So that's a really nice effect. And child neglect, which is, I think, really important in our context here in Arizona. But then you see these improved nutritional quality and reductions in trajectories of obesity and excess eating. So those were things we never intended to influence through this program. There is nothing in this program that says, eat better food and get physical activity. Oh, we also have effects on physical activity. It hasn't been published yet, so it's not on the slide, but it is there. But we don't target that at all. So, but being researchers who like to study everything under the sun, we happen to have it in one of our measures, and somebody thought to say, hey, let's look at this. And I'm loving it. Just to kind of drill into that a little bit more, I have this super ugly slide that someday I'll make pretty, but for now you can see the way that our effects work is that the intervention effects on what we call positive behavior support. So that's kind of structuring the home environment to have positive interactions between parents and children, and kind of, using those strategies like, maybe don't go down that checkout lane that has all the candy. Just the things as simple as that. And that was related to nutritional value of the meals that were served in the home. Honestly, I think we need more, to figure out a little bit more about why that might be, but that has a relationship with the trajectories of BMI, which actually, so this is the Z-score, the BMI, which we aren't using. This was like the measure you were supposed to use when this came out, but now they're like different measures. You don't have to get into all of those details, but basically what we found, just to kind of clarify this a little bit more, is that in the control group, the rates of obesity were going up twice as much as they were as in the intervention group. And then the number of kids who were kind of in that elevated BMI range was coming down, not quite twice as much as in the control group, but really positive effects there. So at that point, we started to think about adapting the family checkup to specifically address health behaviors. So this is a really long, and we were just talking about building partnerships and how challenging it can be. So this has been a long time coming, basically, this study. So a lot of the work that we have done started out at Children's Hospital. I also worked there 1 day a week. And JD, who was my MPI, he also did an internship there at Children's Hospital. So we started there. I used to work in Gen Peds, and I did a survey of physicians and to know what are their top concerns for the families coming in. And obesity was number one. Nutrition, education, and diet was number two, and parenting was number three. So there's a clear need for that from the perspective of the physicians. So that gave us a lot of hope that maybe family checkup is something that could be embedded within primary care. Of course, there are some challenges to delivering things in any kind of primary care setting. It's very fast-paced. Providers don't have a lot of time with families. I think they have to cover more than 20, depending on the age of the kid, different topics in like 15-minute, 20-minute span of time. It's impossible what they're asked to do. So there are definitely some things that you have to figure out in terms of implementation about how this would actually work. But we did do a pilot feasibility trial in both Gen Peds and the Fatty Liver Clinic, and it did seem like there was that acceptability on the perspective of both families and pediatricians. So that was kind of a good starting point. And the way that we had talked to physicians is that the family checkup for health is kind of a bridge between what they're telling families in the clinic setting and then what families can actually achieve. So, we would see this pattern where, a child would come in, physician would say, oh, your child has elevated BMI, so you need to cut out the sugars, add more veggies, reduce the screen time, get more physical activity. And the parent is like, oh, yes, of course, I'm definitely going to do that. As soon as I get home, we're going to, and then they get home and then they spend a lot of money to make something healthy, something they hadn't made before, didn't come out that great. Kid says, yuck, I'm not going to eat that. There's a temper tantrum. And then they basically give up. And then the next time they come back for an appointment, nothing's changed, or maybe it's gotten worse. The family's ashamed, and the physician thinks that they're just non-compliant, and there's a lot of blame there, and then maybe the family doesn't come back the next appointment. So it's really not setting up families for success the way our traditional model is. So what we want is family checkup for health to be there to not replace what the physician is saying. So we're not really trying to say, repeat what they're saying or take their place, but it's really about like, okay, given what they just told you, how are you going to make that happen when you get home? And so we're hoping, that results in greater motivation and ideas about how to really make it happen in a way that is not going to lead to conflict or that coercive cycle. So to kind of drill down into like, what are the adaptations that we actually made here? And we worked with we have had an advisory board along with us to help us make these adaptations. But kind of the gist of it is breaking it down by the different components of the family checkup for health. In this the assessment, we have added some health behavior measures, and then we also have for this particular study, we measure like body fat composition, BMI, and all of those things. And then in our, we adapted our the videotaped interaction task that I mentioned, so that instead of playing with toys, for example, one of the activities is just asking the child, like, tell us what your health goal is, and parents talk with your child about how you're going to meet that health goal. And then we code the interaction based on a number of things, including, relationship quality, the parent's level of support. But then we've also added in a piece about like their understanding about what about the health guidelines, really. And then the feedback and motivation session. I think I actually have a picture of what. Oh, I do have slides about all of this. So you can kind of see, going back to the assessment, these are all the things that we measured in the original family checkup. And then these are the things that we've added. So we have things like health behaviors, body image, their experiences of stigma, quality of life. And then for kiddos who have asthma or diabetes, we have some questions about, how well are those things under control. So this is what our feedback form is. So, so the person who's delivering the program, we call it the Family Checkup for Health Coordinator, but they basically plot out the results of the assessment on each of these domains. So from the green to red, the stoplight kind of thing. And we found this to be something that families can really understand. And then so it started out with just these three, and we've added two more up on top. I think it zooms in. Oh yeah, so the family health routines and the child health behaviors. And we put those front and center because parents kind of understand, like, I'm here, you referred to me by my pediatrician, I'm here for health behaviors. And sometimes it's a little bit of, you really have to connect the dots for them to say why parent plays a role. Like a lot of parents are, oh, go ahead.
Are these mostly Hispanic families?
Mm-hmm, they are, and I will get into that a little bit more later. Do you have a specific question about that?
I'm just curious of the literacy level.
Yeah, so
I saw the iPad and then this.
yes, true. So we had somebody helping them with the iPad, and then for this, it's the coordinators going through it and explaining the whole thing. And actually what they do is they give families a blank form to start with, because when someone gives you the results of your personality assessment or whatever it is, you're like, ooh, I want to see, and you're not really stopping to think about what the whole big picture is. So they show them the blank assessment form and explain each of the sections first, and then they actually go through the one that's filled out. Feedback form, and then go through those details. But I'll talk a little bit more about that in a minute. But oh yeah, so you have to really, sometimes for families you need to connect the dots about why parenting would be something that was related to their children's health, because that's not something that's always talked about. All right, so now I'm getting more into the details of this specific study. It was funded by the CDC with the CORD 2.0. We are now in the CORD 3.0 phase, so CORD 2.0 is wrapping up. But the goals of the study is basically a hybrid effectiveness implementation study. So we had aims related to how well does this program work, and then to learn about how it might be integrated into a primary care setting. One of the requirements of the CORD funding was that it was a program that showed evidence but wasn't an evidence-based program yet. So it was kind of perfect for our situation. We really lucked out. So for this study, we were looking at 6 to 12-year-olds with elevated BMI, and they were attending a primary care clinic. And they could be identified during a well check or a sick visit, or at one point towards the end of the study, because we wanted to get as many people in as possible, we looked at EHR, we pulled data from the EHR to see which kids were eligible, and then we invited them to participate. And they could either be referred by the resident or attending that was with them, or a member of the study team who was an employee of the clinic. And the only exclusion criteria we had was that, you know, there had to be a primary caregiver involved because it's a parenting intervention. And that person had to either speak English or Spanish. At this point, we're not able to really go beyond that, but that was, you know, that's the primary population at the clinics we were working with. Anyway, so that was fine. So we had two different delivery models. We were working with Phoenix Children's Hospital, and unfortunately, we were thinking that, so Phoenix Children's Hospital has a care coordination program, and it was really great. It seemed like a really great fit for the family checkup because care coordinators would do a comprehensive assessment with the families, and then link up families to resources in the community and use motivational interviewing. So that sounds kind of familiar, right? That's really what a lot of the family checkup is, but it just was missing that parenting component. And we had trouble finding evidence-based parenting programs in the community that we could refer families to. And we felt like it was a really big need that was inhibiting a lot of the work that we were trying to do with to promote children's health. So we thought it was very important. We thought that when we started this project that the care coordinators would get trained on family checkup for health and deliver that. And then of course, care coordination is not a billable expense. And so it was grant funded, and PCH lost their grant funding for care coordination before this was funded, and got rid of all of their care coordinators. So these are the kind of things happen when you do implementation research. So what we ended up doing was having employees of our group deliver the program, and it was more of like a referral model for PCH. And then for Teros and Valle del Sol, which are two federally qualified health centers in the Valley, they have folks on staff who can deliver the program. So they have some degree of collaboration between their behavioral health and their primary care. And each clinic has it set up a little bit different. At Valle, they have behavioral health consultants directly in their primary care setting, and they're constantly interacting with the pediatrician. At Teros, they are more separate. They're actually in separate buildings in some of their clinics. So, you know, you say primary care, and that like as if it's a monolithic thing, and it's not even close. We had three clinics, and they all had totally different setups and resources. And then by the end of the project, we started taking referrals from other clinics, and this is the list of clinics that we were connected to in some way or another. Some of them actually gave us referrals. Some of them didn't make it quite to that point yet, but it became a little bit more of this like hub and spoke model. So our study sample was 240 at the end of the day, and we randomly assigned families to either the intervention condition or services as usual. And you can see it's weighted a little bit heavier towards the intervention, and what that allows you to do with just like a minimal effect on your power, it allows you to really tease out some of those implementation questions. So one of the things I'm really interested in is how providers of whatever kind of provider they are deliver the program, and the effects of that on participant engagement and their outcomes. So to test those kind of analyses, you want to have like a bigger sample size in the intervention condition if you can make that work. So that's why we did that. And then this is our timeline for the study. It was a very short grant. It was about the size of an R01, if people are familiar with what that is. But it was about 2.5 year project period. So it was smushed down into about what a normal grant would be in terms of the timeline. So you can see we got our ASU IRB approval in July of 2016, and then didn't get our PCH IRB approval until May of 2017, so almost a year later. That definitely was a challenge for this grant, and something that you run into when you have partnerships like that. So we started enrollment in 2017 in April, finished in November, and then data collection just finished up this month. So when I said hot off the press, I was serious. And then our services ran from August of 2017 to August of 2019. So I want to talk a little bit about the participants who enrolled in the study. You can see the vast majority are from Phoenix Children's Hospital. So we were kind of hoping that we might be able to break things down into looking at, what was going on at PCH versus the FCUs. And we won't be able to do that just because of the small sample sizes, but we did learn a lot from that partnership. So I think it's actually a really good model to have if you want to have an implementation effectiveness trial, that you have some control over some of your effectiveness pieces of the grant. So the PCH part allowed us to do that. And then you can see that the vast majority were referred in clinic. We had one self-referral, and I think a friend of theirs found out or got involved in the project, and then they called us up and said, we want to join too. Okay. And then only 9% from the EHR list, but it's not like an accurate comparison to say that EHR lists are less effective because we didn't start that until the very end of the project, the enrollment period. This is what our BMI breakdown looked like. So we had 81% of our kiddos that were either in the obese or severe obesity categories. So that is very high, higher than we expected. The borderline one is they were elevated BMI when they were referred, but then by the time they came to us, they had dropped right down a little bit below the threshold. There's a little bit of bouncing around that goes on.
Sorry, question.
Sure.
It could have been because of who was referred to you from the
Oh yes, in terms of how high are, yes, I think so. I think that the doctors were definitely looking at the kids who were higher, yeah. And maybe the parents were more accepting if, because at a certain point, you start having to go in like every month for your primary care visits. And so I can imagine parents not wanting to go to PCH every single month. So if there was a strategy they could do to avoid that, that would be great. You can see that this is our gender break, or our age breakdown. They're a little bit more on the higher age range. And I think that maybe speaks to like when they're younger, it seems like baby fat. And then when they get older, you're like, oh, maybe this is something that we need to do it. Or maybe it's that they've been dealing with the issue for longer. So at our CAB meeting, we had a parent come in yesterday and talk about how she had really tried everything. She had tried everything, and she went through, and I mean, it was, all the way from like clinic-based interventions to Weight Watchers, on and on. And so nothing worked until she found us. It was a very nice story, but so I think that's the reason for seeing more kids in that older range, and it was about half and half with gender. And then speaking to your question, we had 68% of our families were Latino, and 38% were, I always hesitate to say this because nobody's like, language is not like a dichotomous thing like we make it out to be. Like most of our families are bilingual, meaning that every third word is the other language. But we had to pick a language to do our batteries in, so families would either choose to do them in English or Spanish. A couple of families started in English and was like, no, let's do it in Spanish. But we did have, like I mentioned before, the interviewer would help families, and we had, native Spanish speakers for those families who spoke Spanish. And both in terms of the people who were doing the interviews and or the assessments, and the person providing the services. So so that that they were able to kind of translate any academies that we overlooked for the family's benefit. Insurance coverage. We found that most of our kiddos were on access, which we weren't surprised about at all. In fact, the CDC was hoping that, it would be a large percentage of access kiddos, so that, their goal really was, the reason for the very short grant period was they wanted evidence to turn right away into practice. So they want us to work with access to get this, assuming we find positive effects of the study, that we, work with them to get it as billable expense so that all kids can have access to it. But then the other thing that I wanted to point out on the slide was the large number of parents. This is the child insurance, and then the darker blue is the parent. 25% of our parents don't have any insurance. So that's something to really keep in mind. Oh, there we go. We have a lot of food insecurity in our population. More than half of the families that enrolled in the study endorsed one of the two questions that we ask about food insecurity, which are, did you fear that your food would run out? And then did it actually run out? So this was definitely something that we were paying attention to, and one of the primary things that we were trying to connect families to in the community was, not just like food boxes, but quality food programs. So that played definitely a big role in our families' situations. And I was talking to someone with the Arizona chapter of the American Academy of Pediatrics yesterday. And that's their big push these days, is to figure out like how to get more pediatricians to ask these questions. Pediatricians are hesitant to ask them, even though they obviously play a huge role with health, because they don't know what to do. They don't want the family to say, yes, I don't have enough food for my family, and they don't have any solution for the family. So their big agenda is like, how can we get better access to support for families and get pediatricians that information. All right, now I'm going to move into service utilization. So I just want to remind you of the structure of the program. So we have the assessment, then we have a feedback and motivation session where we go over, yes?
One question on the previous, is there an average length of engagement for families and number of contacts?
Yeah, I'm just about to get into like, well, I might not have number of contacts yet. So this is all like, it's very messy data, and so it takes a lot of time to clean it. So I do have some of the information related to what you're asking. I might not have that exact piece of information, but so basically it's the assessment that we do, then the feedback session, and then again, parent training modules coming out of the Everyday Parenting book. So up to 12 topics in there, and it's a range. And then community-based resources to address their specific needs. And then this is the length of time that we wanted them to be in the program. So it was a 6-month intervention. And what we did was, this looks like a MasterCard, doesn't it? But this is the assessment and feedback session. And then we would have the parenting modules, the linkage with community resources. We would assess them again at 3 months, and then continue with more services. So at this point, we're kind of seeing like, all right, how far have we come? What's left to do? Are there new needs popping up because we've addressed these other needs, which happens a lot. And then we'd assess them one more time at 6 months, and then do one more feedback session. And that last feedback session, given that it was the end of the program, was really to connect them with an ongoing resource. So who can they call in the future, anytime they have a need come up. And actually, they still call us. So, and we love to be someone that they trust, but yeah, we just had 2 families call us about homelessness. And it's, what do you do? It's so sad. So of course, we're as long as we're there, we can help them. But unfortunately, grants only last so long. So And then we had a follow-up at 12 months for the essentially like 1 year follow-up. The BMI as 1 year was the outcome that CDC was most interested in. So in our feedback and motivation sessions, 80% of families in the intervention condition came to at least one feedback session, which is actually higher than other family checkup studies where they're that they've done in the past. So we feel pretty good about that. Of course, there's probably more we could have done in the engagement process, but 80% is pretty good. So, and of those who ever attend, because that's really the first part of services. So you would never get the parenting modules or the connections with community resources until you've gone through that feedback session. So 2/3 of families engaged in at least one parenting module. The mean number was 2 and the range was 0 to 12. This is higher than in previous studies. It was actually 1 in previous studies. But the mean time for the parenting modules was almost 3 hours. So we expected it to be between 30 minutes and an hour. And so it turned out, we were talking to the coordinators yesterday to kind of get their perspective on what is this about? And basically they said that there were 2 pieces of it. It was hard for families to make time to attend a program. So it was easier for them to do, like, once they got a slot of time, cram as much in there as possible, which first made me a little bit nervous because what is this statistic? Like, you only process about 30% of what people actually tell you. But we talked a little bit more, and it seems that families really needed to first vent a little bit about their situations. And there's so much stigma related to obesity, and there's so much self-blame that parents are feeling that they really just needed to get some of that off their chest before they were ready to dive into like the solutions. And so it was the right thing to do to just talk. And then because they had them there, they did cover multiple points, but the way everyday parenting modules are set up, it's really the family that's doing the most of the talking and the work. And it's kind of like, well, here's something that could help. How could you make this work in your home? And so then it's up to the families to kind of, we're there for support, but they're the ones who are really driving the ship in terms of, what they're going to do next. So it's just a really interesting finding. It doesn't really fit into the primary care model, unfortunately. Most of those kind of behavioral health sessions are about a half an hour. So we're going to have to really think about what this means for future delivery. And then the other piece of things is the referrals to community resources. So 92% of families received at least one referral, and that's a little bit awkwardly phrased, but basically of those families who received a referral, that referral met their needs, and they said in 100% of the cases. So it might have been the first referral that they received on that topic, but basically the coordinator was able to help them find a program or a service to meet their needs in 100% of the cases. And at some point I'll be able to say, like, what are, the most common referrals that were made. At this point, I can't say that, just because we need to do a little bit more data cleaning, but I know food insecurity was one of the big ones. Hello, there we go. And then we measured how much we were referring to them to these kinds of activities too. And we wanted to know how much time they were spending in these programs and services. And this was something that the CDC was also very interested in. They wanted to know essentially, how many families were getting like 25 hours of service, which is kind of the guideline for kids with obesity. So we found, this is the number of hours. So families reported in a 6-month span, on average, 21 hours of time of engagement in like sports or other physical activities. So that'd be like, oh, okay. Like taekwondo or something like that. And then, but one of the things we really encouraged was like more informal activities. So things that families could do together with their children that was like something that would get them off the couch, you know, it could be just like walking around at a museum, or it could be, I forget what they're called. Phoenix, the city of Phoenix has like fun activities like Zumba and stuff like that, that we would try and get the families engaged in. So there was quite a bit of that, 34 hours on average. We were really hoping there'd be more of this community gardening piece, because that's such a like fun thing to do as a family. It's also physically active, and it does encourage kids to eat more vegetables. So we didn't see a whole lot of that, and it may just be that there wasn't as much around as I was hoping, that, you know, as many resources as I hoped that there would be. And then the nutrition classes was kind of limited too. But I think a lot of that really got incorporated into our everyday parenting sessions. We really tied like, you know, like supporting positive behavior. We would embed that within like, how do you cook together and have fun that way, and eat healthy. So I think maybe that was the reason for that. All right, I'm going to kind of zoom through this because I have 10 minutes left. Oops. I didn't mean to zoom that fast. So we were interested in why did certain families engage? And at this point, we're looking at kind of 2 indicators of family engagement. So the study enrollment, like did they enroll in the study? And then if they initiated program services. So that means did they ever come to a feedback session? Because that's that first point of contact for us. And we were looking at 3 different domains of predictors. So family characteristics, child health, and then the referral source. So these were the characteristics that we've looked at so far. There are some others that we're going to move into, but I'll just quickly cover these. So ethnicity is one that I'm very interested in with the group-based interventions that we've done. We usually find that acculturation is related to engagement. And a lot of that work has been done here at ASU and then elsewhere, but basically what we find is that like Spanish-speaking, and this ties into language too, Spanish-speaking families are more likely to come to sessions than English-speaking families. And we were interested to see whether that would be the case here, given that it's not a group-based intervention, it's kind of a one-on-one. So you get less of that reinforcement of the group in this situation. We are also interested to see the effect of insurance and then food insecurity, if that would make them, encourage families to engage more. So we did find that Latinos were more likely to enroll in the study than non-Latinos. But we did not find that they were more likely to actually come to their first program session. So that did not translate. And we need to like think more about why this might be. And it wasn't that they were less likely, it was just that they were not more likely to attend. So maybe that, well, I don't know. There are several reasons that I'm thinking about that could be a reason. I mean, one, the most straightforward one is that they were motivated by the participant reimbursement. But, you know, we don't reimburse families for attending program sessions. So that's definitely something it could be, but we will look more into that. But in terms of all the other ones, we did not find any effects. So families with food insecurity, equally likely to enroll in the study and attend sessions as families without food insecurity. So that didn't seem to be a driving factor. Then we looked at several indicators of child health status. BMI, their quality of life, and then their diagnoses, so metabolic, endocrine disorders, respiratory diagnosis, or behavioral health diagnosis. And this was kind of like a remnant of the original family checkup did have behavioral health outcomes, and we don't expect those things to go away. We still expect this program to affect the behavioral health components in addition to the physical health components. So we wondered how well we conveyed to families that this could help with both. So we did find that having a metabolic diagnosis influence study enrollment. Oh, I just realized I can't see my notes, which is where the results were. But this one was just a trend. And then there was no effect on program initiation for kids with a metabolic diagnosis. for having a respiratory diagnosis. So that would include like asthma, and we did have a bunch of kids with asthma in our study. We found that having an asthma diagnosis predicted your enrollment in the study and your participation in program sessions. So having a kid with asthma is very scary, and it can be made worse through obesity. So I think that that may be one of the driving factors here. Oh, and there's the program initiation. So it had an influence on both. And then behavioral health also had an effect on study enrollment and program initiation. So the effect sizes were, or it was about like, these diagnoses made families about 2 times more likely to enroll in the study and engage in services. And then finally, referral sources, the last one. So we were interested to see, we think that providers have a lot of sway, families really trust them. So does a referral from the provider make a difference in terms of them coming to the program? And then we were also interested in whether, if they were there for a well check or a weight check, did that have an effect as opposed to like a sick visit or some other kind of visit? Are they more kind of motivated if they're coming in for a weight check because, you know, they've been told that they really need to make some changes? And then the well check we thought also might be more conducive to engagement, because really you're there not in a crisis mode, kind of thinking of like, how am I going to deal with what other health issue is going on, and I can really sit there and listen to what the provider is saying about this program. So those are the things we looked at here. And we did find that either an in-clinic provider or any other clinic staff being there on site was related to more study enrollment than if we contacted them through the EHR, which is not that surprising. But then once it got to like actually engaging in services, it had to come from the pediatrician. Our clinic team that was not, you know, the support team that was there, that did not translate into them coming in for services. And then weight checks predicted study enrollment. And I think there is that kind of impetus there, like, oh gosh, we have to come in every month. Maybe this will help us. But it was actually the well child checks that resulted in higher levels of initiation and services. So I think, like I was mentioning, that it is being able to really hear about what, you know, what this program is about, and focus on that so that they would actually show up for services. And I think that's the end. So do we have any time for questions? Okay.
Well, first let's give Cady a round of applause. Let's open it up for questions.
Yes.
So you surveyed the pediatricians, right? And they came up with those top 3
Yes.
issues.
Yes.
Have you ever surveyed the participants and see if those match up?
With their health concerns, you know, we haven't done that. We should do that.
Maybe still, you can still touch on, you know, the top issues that are probably the real issues, but in the perceptions of the participants, find a way to address those issues by addressing their, you know, specific
Right.
things that they think are the most.
Yeah, a lot of prevention, it's like the same intervention has effects on multiple outcomes, like I was showing you before. So if we had, if family said like, yeah, what really bothers me is when my kid doesn't clean up his room. You know, I couldn't care less about, you know, if he's a little overweight, you know, that's just baby fat, or that's just, you know, he's a healthy boy, or, you know, we can use these same parenting skills and just like focus them in on whichever outcome is relevant to the parents, but they're still learning these skills and can apply them. But we should do survey of the whole like patient population, right? I do wonder if different things, you know, eventually we'll be able to get into like their baseline scores and how that influences their program initiation. So it'd be interesting to see if those families who scored in the higher risk categories related to, say, child behavior were more likely to come than those whose risk factors were more around like the physical health. So we could look at that.
I'm also interested to hear your thoughts on, so you said you had some families come back, and this is a research study, you're on a timeline, and so you can't really do much about it because you said you were going to do something, and you're doing that. Now you want people that want more of it, but you can't really.
Yeah.
We kind of have the same thing in the lifestyle intervention that we run. And
Do you work with Cady?
Yeah.
Yes. Okay.
I mean, what's the next step to try to? How do you address that in real time, and then what's the solution? I guess they're down the road, obviously, to implement the program so that it's running in real time.
Yeah. But it takes a while to get that to happen for
Yeah,
sure.
but
And like
it
families
seems
when
like-
they're homeless, they're like homeless right now. They're not homeless, you
Yeah.
know, in a year or two. So
I guess it just seems a little, it's like a little bit of a guilt trip that happens on our end, I guess. And we know they want help. They're coming back for help. Because we
and
help
that
them.
makes us feel good
Yeah,
that
and-
we did a good job.
I don't know. I
Yeah.
struggle with that. And
Really rough. I guess we just have to keep the funding going. Luckily, we have another project that's starting up, so you know we can kind of like help them on the side and not tell anyone.
have you guys ever considered gathering people from the community to start kind of helping out health workers, or
Like in terms of like
try to take
advocacy.
over?
Oh, to keep doing it.
Yeah.
Yeah, so Ryan and Taros, and that's, you know, they have unfortunately not been able to sustain the program as it was. And I think there's still learning lessons for us to have. We started partnering with another health clinic, Bayless, who has like a slightly different model. And so we're trying to figure out the right model that can support the intervention. But it is a challenge for sure. They really like the everyday parenting. They're like, if we could just do that part. Well, I guess you could. I don't know if it'll be as effective, but you wanted to say something.
I think you sort of answered it a little bit, but what would be your next step for a program like this?
Yeah, definitely. We're working with several health plans who, so let's see, Mercy Care is like amazing and they're so interested in this. Their chief medical officer comes to every meeting that we have, but then every other meeting that I go to in the community for other programs, like he is always there. He is just the most fabulous guy. But then Blue Cross Blue Shield, United Healthcare, and then Access is there, and then, oh my gosh, there's one more that I can't think of. But so we're working with them as we're doing our outcome analyses, and if we can show that we have an effect, they have said they'd be interested in possibly funding. A lot of the pieces of it are already fundable, like you can already bill for them. And in fact, Bayless is billing for most of it. Taros and Bai did do some, their setup is a little different, but then there are other pieces that aren't. So one of the big pieces that isn't is the prep time. It takes the providers a long time to like translate, you know, what's in that assessment into like a comprehensive, cohesive story that makes sense for the families. And they really need to do their homework. And I feel like that's true with any health service. Like, how much time do you spend, like, you go to the doctor and they're reviewing your chart for 10 minutes while you're sitting there waiting for them? And like, how much better prepared would they have been if they had a little bit of time before you came in to review your chart and think about like what would be the right intervention for you next. So that is my big soapbox that I talk about every time I go to a meeting with one of the payers, is like, we need to reimburse for prep time. But yeah, so we are working with Bayless on a new project that's funded by the USDA and First Things First. With that one, we've actually taken a step back. We're going even younger, and working with kids of any weak status. We just keep going further and further back. Someday we'll get to like prenatal. The access person was encouraging us to work on breastfeeding issues, which I think are very important. It's a little bit more of a stretch than we've made so far, but